Okay, so let's start then. Okay, I will not wait any further. Okay, guys, thank you for attending. So just FYI, we do have a recent Instagram channel, but in Arabic, to educate people about inherited arrhythmias in general, in pediatrics and young adults. So please subscribe or not subscribe. What do you call it? Join? No, mu join. What do you call it for Instagram? Anyways, I don't know. Subscribe. Subscribe. Okay. Anyways, follow. Yes. So please follow the channel on Instagram if you don't mind, if you care. And then I have Twitter. I'm active in Twitter as well, but this is less. This is more, EP questions and answerings and responses and so forth. So this is a little bit more high level EP. This is very basic. And then we have obviously YouTube channel where we posted our 16 previous conferences. We did more than 16, but I only posted the last 16. We did a couple that we did not, upload, unfortunately. Anyways, we did not record. Anyways, okay, so let's start. So we recently had 4 congenital complete heart blocks, like back to back. And I figured it's a good topic to discuss and remind everyone of the issues with congenital complete heart block, okay? Okay, so the incidence is around 1 in 20,000 live birth. In Kuwait, we have like around 60,000 live births per year, 60 to 70,000 live births per year. So we will, you should expect 3 roughly babies per year, which is definitely what we usually get every year. It's associated with significant mortality, around 30%, primarily in the fetal period or neonatal period, obviously depending on many factors. And then it is associated with high morbidity, i.e., most of them would require pacing at some point, okay? And then there is many issues with pacing, of course. It might be isolated or associated with congenital heart disease. This is why we always do an echo in addition to function assessment. And if it's associated with congenital heart disease, typically patients have a form of AVSD, like genetic form of AVSD mainly, like NKX 2.5 or Holt-Oram. But if there is no genetic association, the most commonly associated congenital heart disease with heart block is LTGA, of course, and left atrial isomerism. Okay, and then there's like 2% annual risk of developing heart block in LTGA, and usually a diagnosis 10% of such patients will have complete heart block, and then by the time they're adults, half of them will have a form of like a complete heart block of some sort. Okay, obviously the isolated form is what we are going to focus about today. Okay, and it's mostly associated with maternal antibodies, the anti-SSA-RO or anti-SSB-La antibodies. Okay, so that's a fetal transplacental transmission from mom to the fetus. And moms may or may not have clinical connective tissue disease, but again, such babies that are isolated, maybe 80-90% of them will have maternal positive antibodies. Okay, other differential when you encounter a baby with isolated complete AV block, that may or may not be congenital, of course, is like myocarditis, infectious reasons like Lyme, Chagas, diphtheria, rheumatic fever, drug intoxications, and so forth. But these are mostly transient, okay, and not congenital, of course. And then so back to the congenital form, such antibodies can injure your conduction system, and hence you have a form of AV block, can injure your myocardium, and hence you have EFE, dilated cardiomyopathy. And the endocardium is EFE and myocardium is dilated cardiomyopathy. Okay, so it might affect each and every piece of the heart. Okay, part of the heart. Okay, rarely babies might present without heart block, but with EFE and maybe sinus node dysfunction. but without heart block. And such babies might also be, the etiology of the EFE and sinus node dysfunction might also be because of maternal antibody, but this is rare, okay? Anyways, so moms with positive antibodies, the risk of delivering a child with congenital complete heart block is 2%, okay? And if this mother already had a baby with congenital complete heart block, the recurrence rate of the subsequent baby goes like tenfold, almost around 20%, okay? So if mom has already congenital complete heart block baby, the repeat pregnancy, there's almost 20% risk of congenital complete heart block in the new baby, okay? And, in my clinic, I do follow like, a couple of families with like 2 congenital complete heart block siblings, okay? So it definitely happens, okay? And obviously, sometimes you do identify a patient with complete, you believe, isolated congenital heart block, but with the absence of antibodies. But such patients are usually present later in life, and they have a better prognosis, okay? Anyways, so that congenital complete heart block usually occurs very early, between 16 and 24 weeks gestation, okay? And then once you see complete heart block in the fetus, this is usually irreversible, and it indicates there is a complete fibrosis of your AV node, and there's nothing much you can do to reverse the complete heart block, okay? So before going to the evidence-based, medicine and literature, I'll present we did publish our outcomes for isolated congenital complete heart block a couple of years ago. It was a retrospective study from 2008 to 2019, okay? We included all our patients with congenital AV block that required pacing at Chest Diseases Hospital. We excluded the patients who, for whatever reason, received the pacemaker abroad, which is probably very few, or associated with congenital heart disease, or there is like long QT syndrome, for example, which might be associated with a form of heart block, which is usually 2-1, okay? We did identify 18 patients over like roughly 10 years, so roughly 2 patients per year, which makes sense. The follow-up time was around 4 years. 12 patients were diagnosed with fetal bradycardia, so there is already established diagnosis in most of them before they are delivered. But there was not much data in terms of data in the file in terms of exact age at which the diagnosis was made, okay? And then the remaining 6 patients were diagnosed postnatally, okay? The median gestational age was around 35 weeks. Some babies born before like 35 weeks, the indication was twin pregnancy, for example, decreased fetal movements, high drops, and very significant low heart rates. And all deliveries were via cesarean section. And the OBGYN would usually deliver such babies with cesarean section, not because the baby, might not tolerate vaginal delivery, but because there's no way to monitor the baby well if there's no heart rate variability. Fetal heart rate variability is a sign of, health. If there is no variability, sign of distress. But with congenital complete heart block, there is by default no variability, so they cannot assess the fetus. Okay, so this is why they usually electively deliver them via cesarean section, okay? The birth weight was 2.6 kilos, median birth weight, and the initial pacemaker implantation age, the median age was around 5 days, okay? So most of them had pacemaker implantation before, the first week of life, okay? 61% of the mothers had an autoimmune identified disease, for example, SLE, but the remaining did not have any clinical diagnosis of an autoimmune connective tissue disease, okay? So all mothers that received therapy, like, for example, steroids, during pregnancy, delivered babies with congenital complete heart block anyways, okay? So there was an attempt to treat the mothers to prevent complications of congenital heart block for such babies, but all the mothers that we treated, not me, I mean the fetal group treated, they already delivered babies with congenital complete heart block. The indications for pacing is usually high-grade AV block or congenital complete heart block. There was one strange case with high drops and 2-to-1 conduction and VT, and in order to treat his VT, we had to give him beta blockers, and because of his 2-to-1 baseline, we gave him pacemaker. So this is one unusual odd case, but otherwise the indication was high-grade AV block, meaning not 2-to-1, higher than 2-to-1, or congenital complete heart block. And then of note, 2 babies were born with 2-to-1 initial conduction that progressed rapidly to congenital heart block within less than a year. Okay, so that's I will go very quickly here because it's just we have so many slides. But so again, we had 18 patients. Okay, like we said, you know, around 60% of the patients had mothers with positive autoimmune disease, and you know, couple were tested positive for the antibodies, but most of them either we don't have the data or they were never tested. But definitely, indeed, like there was 6 mothers with documented positive antibodies. The babies, there were 4 babies with dilated cardiomyopathy, whether it was at birth or developed later in life. So there are 4 of the 18 who had DCM at some point. And I will obviously when we pace, we can pace initially temporary with transvenous system or epicardial system. And we had 3 babies with initial transvenous pacing system, and the one baby had leg congestion, which is not a big deal, but we had 2 perforating transvenous leads during that temporary stage. So we had 2 2 documented perforation from the transvenous temporary pacing system in our cohort. Okay, we had 4 deaths, and we had 4 patients with wide ventricular escape, and and out of the 4 patients with wide ventricular escape, 3 of them died. So if you have a junctional escape, meaning your QRS is narrow, this is a good sign. If you have a QRS that's wide, this is a bad sign, and this is why we often are not comfortable with the wide escape because of the high risk of mortality with such patients. Okay. Anyways, so we placed the ventricular leads. Most of the ventricular leads that are placed was on the RV, and these are examples of RV lead placement. So most of them are either on the diaphragmatic surface of the RV or anterior surface of the RV. But most recently, we are encouraging the surgeons, Dr. Vadim, Dr. Mustafa, to implant a more apical lead, and I'll mention why in later. But so this is an example of a more apical lead position. This is an example of a more RV anterior surface position, and this is an example of an RV diaphragmatic surface position. Okay. Everyone can see my pointer, right? Okay. Yes, guys?
Yes.
Okay. So again, the indication of pacing, besides being congenital complete heart block and high-grade AV block, the heart rate was generally low, with a median of 50 beats per minute. And all patients had epicardial permanent system, except for one had transvenous system, but he presented at 6 years of age, so he was at his size was good for a transvenous system. Okay, so just so you guys know, so this is our epicardial lead that we use. So it's a bipolar lead, meaning you have 2 electrodes, okay, and it connects to the generator here, okay. And if you see very carefully, there is a white band on one of the poles. This is the cathode. This is the most important lead, or like pole of a lead. So this is called the cathode, and this is where we prefer to we want this button to be in good attachment with the myocardium, and preferably at the apex, like we said, especially this this part of the pole, this pole, okay, the cathode pole, okay. And if you, this is zoomed in picture. This is, by the way, I took this image, nice image from Jeffrey Twitter account. He's a very famous pediatric electrophysiologist. Anyways, if you look very carefully, so that cathode goes directly straight into this piece of the lead, and the anode, when it goes to this connector piece, it turns acutely towards the cathode, and then wraps around the cathode. Okay, so if the lead would break here, usually the anode breaks before the cathode. But if the lead obviously breaks here, then you have no protection, or you have less protection. But if the lead would break in this part of the lead, usually the anode is affected before the cathode, and that's fine because you can always switch the pacing mode from bipolar to unipolar using the cathode only. Okay, so that's why this pole is very important, and this is why this pole, the surgeons needs to really make sure that this pole, at least this pole, is like well adhered to the myocardium and good position and everything. Okay. And when you do X-ray, you would that Y piece, that connector piece, would look like, it looks odd, and then people might think, for example, this is an X-ray, might think there's a fracture here, but this is how it looks like. Okay, so if you see, at this Y connector, what looks like a fracture, it's not fracture. This is how it looks like. Okay, usually it's like a thin part here that is not very clear on X-ray. But if you see like a discontinuous, discontinuation in the lead outside that piece, then obviously you have to suspect a fracture. Anyways, and then interrogation of the lead or the pacemaker there would be signs of fracture, meaning loss of capture and increased impedance and so forth. Okay. Anyways, usually we implant single chamber device because of the age, because of the size, because usually it's well tolerated anyways. But we had 3 patients who had initial DDD, meaning dual chamber atrial and ventricular lead, because they were older at presentation and like they were a couple of months already, and it was easier to implant a bigger sized device. Okay, so this lead that we use is steroid eluting. So this is why usually it will performs very well. Thresholds are usually good, and it lasts for many years. Okay. Okay. Anyways, so the longevity of our patients during the study, the first generator longevity was around 5 years, which is acceptable. The leads were all functioning well at the end of the study period, except for 16%. So we had 19 total leads implanted, 3 failed. Okay. The median hospital stay was around 7 days. And like we said, we had temporary pacing wires initially placed in some patients before the permanent system, like a 2-stage repair, meaning you implant temporary first, and then a couple of days later, you implant the permanent. 3 transvenouses and 5 epicardial systems, temporary systems. And these transvenous, like we said, we had 2 ventricular perforation. The epicardial, we had 5 systems, or 5 patients underwent temporary epicardial system, and we did not have much complications. We had pericardial effusions, but usually like non-life-threatening. Okay. In terms of the permanent system complication, we had 1 infection that required replacement of the system, and we had minor, like superficial infections and a little bit of fusions and pocket effusion. But we had herniation of the generator. During this time period, we had 1 patient, but thereafter, we had a couple thereafter, after we published the study. So it does happen. Okay. And we had 1, like we said, 1 permanent transvenous system that had no complication. Okay, in terms of death, we had 4 babies that died. 2 patients died before even receiving a permanent system, only like died during the temporary stage. 1 was severe premature baby, 28 weeks, very low gestational birth weight, 1.2 kilos. And the other one had a syndrome, like he had short limbs, contractures, syndactyly, skeletal dysplasia, acidosis, and had already dilated and cardiac dysfunction at presentation. So only received temporary and died thereafter. Okay, and very recently we had a similar baby, like with short limbs and contractures and skeletal dysplasia. Same story. Died after we implanted the device. So this is, I'm not very sure what syndrome it is, but we encountered such babies twice at least. The permanent cyst, we had 2 patients dying after they received a permanent pacemaker. Both of which developed dilated cardiomyopathy following single chamber pacing, and they underwent upgrading of the pacing to CRT, meaning we implanted another LV lead, kept the RV lead, and we added an atrial lead. So there's an atrial lead, RV lead, and LV lead, but they still did not survive. So overall, we had 4 DCMs in total, 3 died. Okay, so when you get DCMs, that's usually a bad sign. Okay, and at least during the study period, 2 patients developed DCM but did not even respond to biventricular placement or CRT system, and maximal medical support, of course. Anyways, so generally the incidence of dilated cardiomyopathy in isolated congenital complete heart block is between, depending on where, which study are you looking at, it's between 2% to 25%, but among the larger studies. And in our case, we had 22%, like 4 out of 18. Okay. Generally, risk factors for developing DCM is, if you obviously with long duration of follow-up, if the patient presented early, if there is positive antibodies, if you pace the RV, it has shown to be a risk factor to develop DCM, at least in some studies. And in terms of our study, we thought that when you have a wide ventricular escape, and in our case, it was a left bundle branch block morphology escape. Like we said, we had a couple, and they all died. Okay, so wide escape is usually not a good sign, and it's a risk factor for DCM and subsequent death. Okay. So most recently, because of the RV pacing being a risk factor for DCM, and once you have a DCM, it's a high risk mortality, people advocated to pace the LV or BiV pacing instead of RV pacing. Okay, and there are reports of improvement after LV pacing. But counter arguments to that, to the LV pacing is obviously most of our patients that are RV paced are developed fine and they don't develop DCM. And then some patients develop DCM even before you pace, so maybe it's not related to pacing anyways. Okay, so there is a debate, but definitely there is evidence that LV pacing is generally better than RV pacing. Okay, so going forward, most recently, the past 2 years roughly, I'm always recommending apical pacing as much as we can. Okay, so for that paper, in conclusion, we all of our patients needed early pacing, like early need of pacing, but we had overall few complications from pacing with good lead performance and battery longevity. But once there is DCM, usually it's associated with bad outcomes. Okay, and left bundle branch block escape rhythm was associated with bad outcomes. Okay, so these are references for our paper, just for your information. So now, so what evidence do we have? So now we know it's a disease that has good mortality and good morbidity, so it's best to avoid it, of course. So the question is, can we prevent congenital complete heart block in mothers that are at risk, meaning antibody positive mothers? This is one question, and the other question is, say we could not prevent the congenital complete heart block, but can we improve the survival after the congenital complete heart block diagnosis is established? Okay, So let's discuss what evidence do we have in the literature. So this is a paper that was published in 2020, okay? So obviously very recent paper. It was regarding the use of hydroxychloroquine to prevent congenital complete heart block in mothers that are with positive antibodies. Okay, so there has been anecdotal evidence that hydroxychloroquine might prevent congenital heart block in couple of previous smaller studies. Okay, but they were all retrospective. Okay, so that's a prospective trial. Okay, so the study was initiated to address whether hydroxychloroquine reduces the recurrent rate of congenital heart block below 18%. So remember, like we said, mom that is antibody positive, she's at risk of having a child with congenital complete heart block. The risk is 2%. Okay, but if she has already a child with congenital complete heart block, the risk goes up to around 17-18%. Okay, remember, guys. So they conducted this study between 2011 and 2018. Okay, and what's called, by the way, the patch study. Okay, so they included mothers that had previous pregnancies with congenital heart block or cardiac injury, and they had positive antibodies. So mothers with positive antibodies with history of a baby that had congenital heart block or cardiac injury thought to be related to the maternal antibodies. Make sense, guys? So they collected, they collected such mothers, and they gave them, for the next pregnancy, they gave them hydroxychloroquine for 100 milligrams before 10 weeks gestation. So it's very early, okay? And they maintained that dose throughout pregnancy. Make sense, guys? Everyone understands that's the inclusion criteria? Because it's important. Yes?
Yes, Dr. Mohammed.
Okay. So obviously they excluded, if there's congenital heart block, they excluded that mother. And if the mother was already given something else, like for example steroids, they excluded the mother. Okay, so after they started hydroxychloroquine at 10 weeks, at or before 10 weeks gestation, they started doing echo at 16 to 18 weeks gestation, and then weekly thereafter until 26 weeks gestation. Okay, so they stopped doing echoes after 26 because it's very rare to develop heart block after 26 weeks. Usually if the heart block would start, like we said before, it's before 26, 24 weeks gestation. Okay, it's very early, okay, during pregnancy. Okay, so obviously the endpoint was if there is recurrence or advanced heart block, okay, whether in utero or at birth. And there are secondary endpoints, like for example, like first degree heart block, myocardial injury, EFE, and so forth. Okay, so the initially they were able to include 24 mothers. Okay, but they excluded 5 of them because they started their hydroxychloroquine either like low dose or like beyond 10 weeks gestation. So after the 24, they excluded 5. They were left out with 19 patients. Okay, so they included those 19 patients, and then later they enrolled another 41 mothers, but they excluded another 5 for various reasons. And so they are left with another 36 mothers. So in total, they had 54 mothers that had history of baby with congenital heart block, plus mom is antibody positive. And obviously, they gave them hydroxychloroquine at 10 weeks gestation or sooner. And then they did multiple fetal echoes and so forth. Okay. So long story short, in brief, roughly they had in total 54 mothers. Okay. And after the 54 mothers, the only 4 had baby with heart block. Okay, so the risk was down to around 8%. Okay, so like we said before, the historical rate is around 18%, so it went down to 8%. Okay, so around half, 50% less. Okay, so that study, which is a prospective study, like we said, this is the first evidence that hydroxychloroquine, like this is the first time someone proved prospectively in a like well-organized trial that there is something that you can do to prevent developing congenital complete heart block in mothers that are with antibodies that are positive. Okay, so so these are like, remember we said there are 4 patients who had heart block in this study, and these are the details of the patients. So I will not like elaborate on them so much. Okay, so in conclusion, so the recurrence rate was reduced down to 8%, 7.4% to be exact. Okay, and the recurrence rate, like we said, defined as either 2nd or 3rd degree heart block. Okay, so the hydroxychloroquine at 400 milligrams, was micrograms or milligrams? It's milligrams, sorry. So the hydroxychloroquine is the first medication shown to favorably alter the fetal cardiac consequence associated with maternal anti-SSA rho antibodies. Okay. Yes, question about hydroxychloroquine. So by the way, so again, the problem with hydroxychloroquine is that you have to start the hydroxychloroquine very early, like 10 weeks gestation, like and most of our mothers that come to us usually are beyond 10 weeks gestation. So we need to obviously educate our OBGYN friends that such mothers that are at risk, they have to be referred to us right away, and then we have to start hydroxychloroquine right away. And there's no real side effects from hydroxychloroquine, by the way, okay? Like to the fetus or to the mother. It prolongs the QT and stuff, but with monitoring, usually it's very well tolerated and the side effects are very minimal, okay? Okay, so what other studies do we have? So there is an older study back in 2003 regarding prevention of recurrent, same thing, prevention of recurrent congenital heart block but this time with IVIG and corticosteroids, okay? So they only had 8 mothers with history of positive antibodies and history of babies with congenital heart block, okay? So out of these 8 mothers, such mother were treated with IVIG at 1 gram per kilo at 14th and 18 weeks gestation. And then they gave them also prednisone at 14th weeks gestation, 40 milligrams daily, tapered to 20 milligrams daily at 16 weeks and 10 milligrams daily at 24 weeks. Okay, and then continued at the lower dose towards the remaining of the pregnancy. Okay, and anyways, out of these 8 mothers, only 1 had congenital heart block. Okay, and this mother who had the congenital heart block, she refused to take the prednisolone. She only took IVIG. So this study also is suggestive of maybe combination IVIG steroids might also prevent congenital heart block, but it's only for 8 mothers. So it's a very low, low powered study. Okay. And it was not repeated and since back in 2003. What other evidence do we have? So now so there is this paper from 2010 regarding, it was also multi-center prospective open clinical trial regarding whether IVIG only prevents heart block, congenital heart block in mothers that are antibody positive. So again, only IVIG in this case. Okay, it was called the PITCH study. Again, prospective trial. Okay, like the hydroxychloroquine study. Okay, so they gave the dose of IVIG was not 1 gram per kilo. Remember the other study, it was 400 milligram per kilo and was given every 3 weeks between 12 and 24 weeks gestation. But the conclusion was that the IVIG given at this low dose did not prevent recurrence of congenital heart block. So they did not, at least at this dose, with only IVIG in 20 mothers, the incidence of recurrent heart block was similar to the natural history. Okay, so they concluded that at least at this dose, and solo IVIG is not good enough to prevent congenital complete heart block. Okay, and that study was also repeated by a different, so this study was done in the US, and an identical study was done in Europe, exactly same dose, exactly same protocol. And again, the IVIG at this dose, which is 400 milligram per kilo, did not show to be effective in reducing the incidence of congenital complete heart block in moms that are antibody positive. Okay, so far we have hydroxychloroquine as a good evidence. We have combination IVIG and steroids as good evidence to prevent congenital complete heart block, but solo IVIG, at least at 400 milligrams, was not good enough. Okay, so this is in terms of what evidence do we have. You know, it's basically that's it. There's not much. There's no much other studies. Okay, now there's a more recent study in 2022 regarding outcomes of, and this is a retrospective, not prospective study, regarding outcomes of antibody-mediated fetal heart disease with standard anti-inflammatory treatment. So what they did was they studied whether dexamethasone, not prednisone, dexamethasone on antibody-positive mothers with neonatal lupus hearts, whether dexamethasone helps in at least not preventing congenital heart block, but at least improving the outcomes. Okay, so it was retrospective, multi-center. They included 130 patients. Okay, 108 with congenital complete heart block, and 22 others with either lesser forms of heart block, or there is, like we said before, sometimes those antibodies will only, the patient might only have EFE or might only have like some bradycardia, but without AV node disease. Okay, the dexamethasone was generally started before 24 weeks gestation. And in some mothers, in addition, so everyone has to be on dexamethasone in this study, okay? But there were patients with beta agonists, and there were patients with IVIG in addition to dexamethasone, okay? So just to reiterate, so this study included, so it was up to 2019, but I think they went all the way back from 2007. So the protocol was all mothers would be started on dexamethasone at onset of diagnosis. Okay, whenever the diagnosis is made, in order to be included in the study, the mother should have been started on dexamethasone. Okay, at a dose of either 4 to 8 milligrams per day. Okay, so once the diagnosis is established. Okay, and like we said, the median was before roughly 24 weeks gestation. Okay, and then that dexamethasone dose is continued usually until it gradually reduced, but usually is weaned off towards the end of pregnancy. Okay, at the 3rd trimester. Okay, and then like we said, some mothers also receive beta agonists such as salbutamol or terbutaline if the heart rate was below 50 to 55. Okay, and or there's ventricular dysfunction. And some mothers received IVIG at 1 gram per kilo or 70 grams per dose between, so every 2 to 3 weeks, okay? And then a 2 gram per kilo dose given to the infant at birth if there's EFE or not complete heart block, but a lesser form of heart block, okay? Again, if you have complete heart block, usually there's nothing you can do. If you have a lesser, form from congenital complete heart block, you might be able to reverse it, okay? But you have a very usually narrow window, less than 24 hours even, maybe, okay? So, and then if the baby still had EFE, still had incomplete heart block, they would also give him prednisone, okay? The baby would receive prednisone and the mother was on dexamethasone. Okay, anyway, so understood the inclusion criteria, guys? It's a little bit confusing, but is it understood? So in brief, all mothers had dexamethasone plus minus beta agonist plus minus IVIG. Okay, guys? Guys, yes? Understood? Questions? Okay.
دكتور محمد ممكن
Yeah.
سؤال؟
Yeah.
هو حضرتك في الأول قلت إن اللي هم المذرز اللي عندهم اوتو اميون ديزيز بيجي لهم بالفيد اللي هو البيبيز بتاعتهم بيبقى عندهم هارت بلوك صح؟ اللي هم بيبقوا ماشيين على ستيرويدز اصلا المذرز دول.
You mean in our study? In our study?
لا لا لا، في الاول خالص احنا قلنا اللي هم المذرز اللي عندهم اوتو اميون ديزيز
Yeah,
هم
not
البيبيز ممكن يجي لهم هارت بلوك،
yes.
فدلوقتي احنا بنستخدم الستيرويدز ك ك كتريتمنت.
Yeah. Yes.
هي
So
بس انا عندي confusion بس في الحتة دي.
what's the confusion? So in
يعني هي عندها اوتو اميون ديزيز فكان بتاخد ستيرويدز، فعشان كده البيبي بتاعها طلع هارت بلوك. دلوقتي انا في الستاديز ان احنا بنديهم ستيرويدز فبيتحسنوا، فبنحاول نمنع الهارت بلوك صح كده.
yes, so the steroids, like in order to prevent heart block, we said there is no evidence except for hydroxychloroquine, strong evidence for hydroxychloroquine or combination IVIG steroids, okay? But with a
تمام
very low
اوكي.
powered study, okay? But
تمام
this study, the patient already developed heart block, okay? So after
اوكي
there is heart block, then they started dexamethasone, okay? So you have to differentiate. This is a retrospective study. The others were prospective studies, okay? So in this study,
اوكي
now there is heart block. So moms were started on dexamethasone and they want to see the outcome of such pregnancy because like we said before, if you have, obviously there is 30% mortality. Remember when I first, during my introduction, I said there's roughly 30% mortality. There is 70-80% risk of morbidity in terms of needing pacing, okay? So they want to see
اوكي
now, maybe it's too difficult to avoid congenital heart block, but they want to improve the outcomes. They want to decrease the mortality from 30% to hopefully 1%. So now in this study, they are studying the outcomes of pregnancies that with pregnancy that already the baby already had neonatal lupus, but now this dexamethasone started after the diagnosis. Okay, makes sense.
اوكي.
Okay.
مم.
Okay, so the results. So such mothers, they had baby survival rates at 95% fetally, 93% neonatally, and at the end, like at 1 year of age, 89%. So the mortality, at least until 1 year of age, is 89. Sorry, is 11%. Okay, so there is in general improved mortality rates. Like before, we said it might be up to 30%. Here, at least at 1 year, the mortality was 11%. Okay, and the risk factors associated with death was atrial bradycardia, EFE, fetal hydros, ventricular dysfunction, very slow ventricular rate, okay, as expected, okay? And then at follow-up at roughly 6 years of age, 85% were paced and one had heart transplant. So the pacing requirement remained high. Like we said before, it's around usually 70-80%. So the pacing requirement did not change with addition of dexamethasone, but the survival rate of such babies had improved. Okay, so the steroids may not have reversed the heart block, but definitely improved the outcomes. Okay, so again, the mortality rate came down with, in this study, with such mothers that are on dexamethasone, all of them, plus minus IVIG, plus minus beta agonist. Make sense, Marwa? Everyone understood, guys?
Yes doctor.
I'm describing many studies, but these
Yes.
are, it's, I just want to make sure you guys are understanding the studies, okay? So it's really difficult to avoid heart block once it starts, okay? And that's an evidence here. But but you might very well be able to improve survival regardless, irrespective of heart block. Maybe so the point of this study, or what they are trying to make, is starting dexamethasone even if there's heart block might not reverse the heart block, but still might improve survival. Make sense, guys? And these are the specific dosages. I mentioned the dosages because maybe our fetal cardiologist, Dr. Mustafa, and Sundus might want to know the dosages. Okay, and there was not much side effects from steroids. There was like 2 patients with mood disturbances, so they had to lower the dose, but nothing serious, okay? And even on babies, steroids are known to restrict growth a little bit on the babies, but in this study, it was not even very pronounced, okay? So, so in general, the steroids, steroids did not help with reversing heart block, but it did perhaps help with improving survival, okay? So that's a very busy table from the study, but really brief. Again, the neonatal survival was, like we said, 93%. So this is our study. This is this study, the current one. And comparing to the largest studies out there, definitely the survival in this study, 93% versus 77%, 84%, 84%, 82%. The survival here definitely is larger than the usual previous studies, okay? And hence, maybe dexamethasone started at onset of diagnosis is a good idea. Make sense, guys? Okay. And like then at the end of the study, 88% of patients were alive in the study. Okay, so meaning mortality is 12%, meaning it's definitely way below 30%. Okay, makes sense, guys? And if you remember from our study, we had 18 patients, 4 died. So that's definitely more than 12%. Okay. So, and then what's also very interesting, they only had 3 out of 100, out of 106 patients, they only had 3 dilated cardiomyopathy. And in our study, we had 18 patients, 4 dilated cardiomyopathy. So definitely the dilated cardiomyopathy incidence went down so much, and probably that's why the survival increased so much. Okay, guys? So makes sense, guys? Okay. So the AHA from 2014, it's not yet updated, but the recommendations published in 2014 is still recommending to observe without use of steroids in patients with congenital complete heart block. Okay. So there is, but after the study, which is just recently published, maybe that recommendation would change. But if you want to follow the guidelines would say, just observe, don't do anything, okay? But again, this paper just published, so maybe the guidelines would change, okay? And this was based on previous older studies that steroids did not do much. There might be side effects to the mother, side effect to the baby, and so forth, okay? But these studies are generally very small, and they included mothers that are antibody positive, mothers that are antibody negative, and so forth. So they were not very clean studies. Okay. Anyways, so and they in that same guideline document, it did say that dexamethasone may be considered to improve survival or reduce the risk of DCM or to prevent progression, but with a class 2 indication. Okay. So anyway, so given that most recent published paper, I think dexamethasone at diagnosis plus minus IVIG plus minus beta agonist might make sense, and we might need to change our practice here locally. Okay. Okay. So in contrast to the past investigations, this study showed better survival rates, again, a lower prevalence of DCM. Okay. Again, 3 patients out of around 3% versus the usual 20 to 30%. In our case, we had 22% risk of DCM. Okay. And by the way, like we said, the pacing requirement remained high. So despite high 85% paced cohort, only 3% or 3 out of 106 had DCM. So the pacing might not be the reason why people develop DCM, because this is a proof that despite high pacing incidence, the DCM remained low. Makes sense, guys? متولي
Yes, doctor.
makes sense.
ايوه
Makes sense. Okay.
ايوه
So this is an evidence that maybe the DCM is not purely related to pacing, okay? But this study support the use of steroids, specifically dexamethasone and IVIG and beta adrenergic agents to reduce risk of perinatal death and postnatal DCM development and hence improve survival, okay? Okay. Anyways, I'm trying to see what I wrote. So I can be fit. Okay. Anyways, so like we said before, for this study, the average weight was 2.4 kilos. Okay. So by there was 30% IUGR babies. Okay, in this study. But this is very comparable to previous reports, whether they were treated with steroids or not. And in our study, you know, our mean birth weight was 2 point similarly, and most of our in a 50-50 in terms of being treated or not. So I think the steroids in this study did not really, you know, the weight was not really much affected by the use of steroids in this cohort. Okay, so the average birth weight remained roughly the same. Makes sense, guys? Plus, so I don't think you know, there is a concern that steroids would, you know, decrease fetal growth, but I don't think it will decrease it very much, because this is a proof that the birth weight in general was comparable to other studies without the use of steroids. Okay, make sense, guys? Okay. 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 So the benefit of improved survival, okay, probably would outweigh the risk of steroid complications to the mother or to the fetus, which is very few. Okay, at least to the fetus. To the mother, you know, obviously there is a risk of, in addition, preeclampsia and everything. But you know, the survival benefits might outweigh the risk to the mother and the fetus. Okay, and then obviously, in general, what we have to, like, when you guys see a patient with congenital complete heart block, you always have to counsel the mother that next pregnancy you have to come to us immediately. You know, they should not wait for the OBGYN to refer them to cardiology. Whenever she knows she's pregnant, she does fetal echo at Chest Hospital. Okay, because again, we might be able to use hydroxychloroquine on her, for example, if she presented before 10 weeks gestation. Okay, guys? So, you know, going forward, whenever you encounter, you know, such mothers with such history, always counsel that for next pregnancies, for her to see, you know, to do a fetal, like cardiac fetal echo, like by Dr. Mustafa or Dr. Sundus or whoever does fetal cardiology, fetal echo, sorry, as soon as possible, as soon as she knows she's pregnant. Okay, guys? Okay. And in our study, for example, most of the diagnosis was made very late, and steroids were started and did not make much of a difference, at least in terms of heart block. Okay. Okay. So that's another paper from 2004, similarly studying the outcomes of babies that received treatment with congenital complete heart block. Okay. In antibody positive mothers. Okay. So there were two study groups. Okay. One group received dexamethasone, okay, at a rate of 90%, compared with another with the second group that received like dexamethasone at much less rate, like around 50%. Okay, so 46% of the second group did not receive steroid, and 90% and 100% of the initial group received dexamethasone, and only 50% of the second group received dexamethasone. And there was reduced morbidity and improved outcome in the the group that received 100% steroids compared to the other group that received only 50% of the cohort received steroids. Make sense, guys? Okay. So there was in this study from back in 2004 evidence of improved survival with steroids. Okay, make sense, guys? But a lower volume study, lower powered study, like 21 patients in one group. Okay, guys? And again, another study in 2011, okay? The use of IVIG and steroids, again, in babies who already have moms with antibody positive and babies with, in this case, cardiomyopathy, not heart block, like babies who already have developed cardiac dysfunction and EFE in utero. They studied the outcome of such babies after they have received IVIG and steroids. Historically, such babies with decreased function and EFE in utero usually is a very bad sign, and this same group had shown that there is roughly 85% babies with cardiac dysfunction and EFE would either die or need transplant. Okay, so it's very high, very bad outcomes. Okay, but at least in this small study, 20 mothers specifically with, again, cardiomyopathies thought to be related to positive antibodies, they were started on IVIG and steroids, and 80% of the patients were alive, okay, with normal systolic function, and 6 were not even paced at follow-up. Okay, so again, remarkable improvement in outcomes. Okay, so treatment of with IVIG and steroids might obviously improve the outcomes of such fetuses with already decreased function. Okay, so again, another evidence that IVIG plus steroids might help improve the outcome. Okay, so makes sense, guys. So this is what evidence do we have in terms of either preventing congenital coronary heart block or improving its outcome without preventing congenital coronary heart block. Okay, there's not much, there's other studies, but they're very small. These are the main ones. Okay, so now the baby is born. Generally, so there's a recent guideline consensus statement from 2021 for isolated congenital coronary heart block. So this is what we should do. Class 1 indicated when there's symptoms. Obviously, in newborns, it's difficult to determine symptoms, but if there's decreased perfusion, renal impairment, mottling, hypotension, these are all obvious symptomatic bradycardia. So if you or high lactates, or if you think bradycardia is causing a specific something that's symptomatic, and then this patient met pacemaker indication. Okay, or if the patient has wide QRS, okay, escape, or has ventricular ectopy, complex, meaning not monomorphic, or if there's any evidence of ventricular dysfunction. Okay, and if there is, and in terms of heart rate, if the baby or the neonate is asymptomatic, but the mean heart rate is less than 50 beats per minute, the mean heart rate, then it's a class 1 indication for pacemaker. So either very slow heart rate, or dysfunction, wide QRS, complex ectopy, or symptomatic. Okay, guys? Okay. And then there is, class 2A indications that I would, usually we go with the class 1 indications. Okay. You can read this doc, this is, you can have this, and, for next, whenever, this is what we use to recommend pacemaker implantation, yes or no. Okay. And so this is a study from 2018. Like we said before, the heart block usually develops rapidly, meaning, one day baby might have a normal heart rhythm, and then the next day he might be in complete heart block. So the AV node disease happens usually rapidly. Okay, and then you have a very small window of reversing that process, okay? So one way that you can, one way to reverse, to, to surveil the patient and hopefully reverse the process is by monitoring fetal heart rate from home, okay? So you can give the mother, Doppler, fetal Doppler, and then once there is decreased heart rate, you instruct the mother that she should immediately go to the hospital, and then because if there's decreased heart rate, this is a surrogate for form of heart block. Make sense, guys? So this is a study that has been done, and perhaps if you are this aggressive, you might prevent or reverse complete heart block. Okay, so this is something that theoretically one day we can do, but obviously this requires good amount of manpower. Okay, and there is a prospective trial that's ongoing. Okay, started August 2020 and will end in 2025. Okay, that hopefully would enroll so many patients, and might show further evidence of how to improve outcomes and maybe prevent fetal heart block. Okay, there has been attempts of fetal pacemakers in the implantation of successful implantation of fetal pacemakers in the past, but these are only experimental yet, and it's not widely used. Okay, so I think, and I don't know whether Dr. Mustafa is here. I don't know whether he joined, but anyways, but since he's our main fetal echocardiologist or cardiologist, sorry, I think we should do our own protocol. Okay, so again, at-risk mothers, meaning they are established antibody positive mothers based on a history of abortions or history of congenital heart block in a previous pregnancy. They should be referred ASAP to cardiology. Okay, ideally prior to 10 weeks of gestation, and if we encountered such a patient, we have to start hydroxychloroquine 400 milligram throughout pregnancy. Okay, and then we should do echo sporadic, on a weekly basis. Again, this requires manpower, so I don't know whether this is possible, but at least we can try. And if with monitoring there was evidence of cardiac involvement, meaning we could not prevent neonatal lupus, we then can switch hydroxychloroquine to dexamethasone. Okay, and then plus we give beta agonist to if the heart rate is very slow, and we give IVIG if there is EFE and dysfunction. Okay, and then some people also give digoxin, by the way, but I did not see strong data about digoxin, but it's definitely being used. Okay, so if we're very desperate, we can give combination therapy, and surprisingly mothers tolerate beta agonists very well, and dexamethasone very well, and hydroxychloroquine very well. Okay, so why not? Okay, and then obviously we should try not to deliver the baby obviously very premature. Hopefully we monitor the baby very closely, and even if there's hydrops, we just make sure it's not progressing, and hopefully with such therapy things would stabilize and hopefully improve. Okay, and then we deliver the baby at or near term. Okay, usually by cesarean section. Okay, and after the baby is born, if there is evidence of decreased function, this is what we should start steroids, and we should also give IVIG. Obviously the volume is might be too high for IVIG, so give it over 2 days. Okay, so that's that is a potential protocol that we could establish going forward. Okay, and then if the baby met pacing indications, depending on the criteria or the guidelines, then obviously we have to immediately pace. And then the immediate pacing, usually there is like we said, usually we try to pace at a slower heart rate and then gradually go up, and there is anecdotal evidence that this is better than pacing fast right away, but the evidence for that is not, based on randomized controlled trial. Is the evidence very weak, but many people would recommend stepwise gradual increase in heart rate pacing, okay? Obviously, if like our recent baby did not like heart, rate of 70 or 80, when we went up to 120, things improved. Yeah, so you don't have to be very strict. You start at 70, 80. If you don't like you don't like the hemodynamics, just go up, okay? But if you like the hemodynamics, don't go up, okay? So you have to take, each baby is a little bit different, but routinely, most people would start slow and then go up. Obviously, there are people who don't do that, who start high at 120 or 110 from day zero. But, there are different schools. I am from this school until, someone convinced me otherwise, okay? But again, we recently had a baby who did not like 70 beats per minute. So, I understand that it's not applicable to all babies, okay? And if we want to pace, obviously, we can either, usually the safest thing to do is to do temporary first, okay, because it is less surgery. And then we want to make sure the patient survives and makes it before implanting a permanent device, which is costly and so forth. But I understand the argument that just do permanent right away because of our ICU infection rate and so forth. Okay, so there, we can debate this with each and every baby. But if you want to have a strict protocol, I think this is the best protocols. Do temporary first and then later permanent. Okay. The temporary, of course, you have two options: epi or transvenous option. And like we said in our paper, we had issues with transvenous not us, it's like very well known. Transvenous option is, yes, it's good, but higher risk of perforation. Okay. And if we have a surgical team that is, collaborating and willing to do epicardial temporary pacing at any day, any moment, then we should use this because it's better for the patient. We should, obviously, thank you, Vadim. I see you're coming. So our surgical team is very cooperative in terms of temporary epicardial pacing. And we are doing this for a while and usually no issues, okay? So I think our best option is epicardial temporary pacing, okay? And then the further benefit of epicardial temporary pacing usually lasts longer. It's more stable, and versus the transvenous is usually not very stable. It moves easier and so forth. Okay. Especially if you are anticipating that this baby would, say the baby is very sick or very small or very preemie, you want to keep pacing temporarily for like 3 weeks. It's probably better, long-term option, probably better epicardial, okay? And then with the epicardial, they can put multiple pacing wires. So they don't have to put 2, they can do 3 or 4, and then we can have multiple options, okay? Anyways, but say the baby was very stable, did not require pacing initially, but later required, then obviously we can do permanent right away because the baby is now bigger, no infection, he's definitely more stable, not as sick as the babies that present fetally or at birth, but most of our babies usually this is how they present, fetally or at birth, and they are usually sick, okay? But sometimes we have babies that are not sick, they tolerate not pacing for 2-3 days, and then we make sure there's no infection, and then if they met the criteria for pacing, usually based on slow heart rate, but without other symptoms, we usually would recommend permanent, but it's just permanent 1-stage surgery rather than 2-stage surgery. Okay. And then if we eventually place the permanent lead or system, we preferably would aim for LV placement. Okay. Apical LV placement. Okay. Especially if there is already decreased function, if there's already DCM, if the baby like had a very bad course fetally, and so like especially if we're very worried there's EFE, it's probably makes much sense to place an LV initially. If the baby is super duper stable, his only indication for pacing is just heart rate slow, you can argue maybe he doesn't need LV, lead, just RV lead, and because it's just easier. But most babies, probably you can argue for an LV lead. And then if there's decreased function and everything, you can also argue for dual chamber implant at onset. But this is very unusual, okay? I think single chamber AV lead is as good as dual chamber system for neonates, okay? Okay, so make sense, guys? So the last two patients that we had, they had a rough course, but they survived. But, again, most of our patients that we receive are not treated, are, not on steroids, are not on IVIG, are not on hydroxychloroquine. So they are usually, your typical 30% mortality rate. Okay? Okay, guys. I don't know who's... Okay. Okay. Questions?
دكتور محمد
Yeah.
كنت أسأل حضرتك على حاجة. لو بيبي دلوقتي لسه زي ما حضرتك بتقول مولود وهو congenital heart block مش عندنا في المستشفى،
Yeah.
هل احنا ممكن نوصل عليه مثلا AED او حاجة عندهم لغاية اما هو يجي لنا، ولا هو الحل بس زي ما حضرتك قلت اللي احنا
You mean
نشتغل عن
transcutaneous
طريق
spacing, not AED. Transcutaneous spacing.
اه
I mean, it's obviously you can, doesn't hurt, but the problem with transcutaneous spacing is obviously is very painful. So the baby has to be intubated and everything. Plus, it's really tricky. The temporary pacing would produce a big artifact on the ECG, and very often people think that we are capturing based on ECG, but we are not. So if you do it, you have to confirm the rate by examining the pulse of the patient. And if you're capturing, obviously it's an option, but it's not a long-term option. It's an option for a couple of hours. It doesn't hurt. But I had seen ICU physicians that are pacing transcutaneously, thinking they are capturing, but they're not capturing. So they are misled by the artifacts, and they think they are capturing and they are relaxed, but the baby is it's not capturing, and the heart is much slower than what they think.
يعني قصدي اللي احنا ممكن
don't be
نزودها
fooled.
في البروتوكول يا دكتور محمد، خصوصا لو البيبي
We
كان سيك
can,
او حاجة ان هم يبدأوا تحت هناك لغاية ما هو يجي لنا.
yeah, but generally the other hospital, they don't know how to do transcutaneous pacing. Generally, I don't know what they know, but we can instruct them. We can, but this protocol is for us, not for other hospitals. This
شكرا
protocol is
طبعا.
for our hospital, not for other hospitals. Okay. Other questions?
شكرا دكتور محمد.
Welcome.
Please, one question, Dr. Muhammad.
Yeah.
Regarding this pacemaker instances, about comparison between temporary transvenous or epicardial and comparable to permanent pacemaker, and also what is the best option if I have patient with sepsis presented, unfortunately, with the infection?
Yeah.
And also another part of the question, what is the cut point for permanent pacemaker insertion for body weight?
Okay. So I'll answer the last question. Vadim is here, he can correct me, but usually, of course it's surgeon dependent, okay? But there is this microny device that is not present, doesn't exist, doesn't exist outside the US and a couple of other countries. We don't have it here, which is a very small pacemaker. So the surgeons can implant it at 1.2 kilos, 1.5 kilos. There are reports of implantation at this very small, weight. But usually the pacemaker is the microny from Abbott St. Jude, which we don't have. Okay, so here locally we are able to implant the permanent device at roughly 1.8, 1.7, 1.9 kilos, like a little bit below 2 kilos. Okay, but I'm not sure whether we can below 1.5 kilos. Okay, so the weight wise, roughly a little bit above 1.5 kilos. Okay, between 1.5 and 2 kilos. Okay, so the last baby that we had, he's at 1.8 kilos, for example. Okay. The second question was sepsis, right? So the sepsis, say he's septic and he needs pacing, you just do temporary wires, okay? And pace him until he's out of sepsis, roughly 10 days, 2 weeks, and then you implant the permanent. Make sense? First question was, I did not understand your first question, to be honest.
Yes, any studies doing comparison between when patient presented sick with bad condition, and especially when inotropic support and unstable hemodynamics. Any comparison between transvenous and epicardial pacing?
You mean now you mean a baby just diagnosed and he's already sick? Comparison between epicardial and transvenous, like temporary pacing, you mean? No, they do all the same job. It's just obviously transvenous is typically probably much quicker, you know. The problem is it's less stable and there is risk of perforation. You know, epicardial is obviously a little bit of a longer procedure, although it's not very long, it's a little bit longer, but more stable and last longer. Okay, but you can do either. You know, they both serve the same function. They will both pace the RV. You know, so the hemodynamics will not be much of a difference. You know, but in our case, for example, you still need anesthesia clearance, you still need blood clearance, you still need all the anesthesia pre-surgery requirement, which takes, you know, many hours, you know.
So another question, please. What's the best steroid if I'd like to give baby? I mean for new.
Well, you know, you know, when if the mom is still pregnant, dexamethasone.
For neonate, I mean for neonate, the best time, I think, best 24 hours, this for sure. But what's the best steroid type for the newly delivered baby?
For moms, Dexa. After they are born, prednisone.
Prednisone.
Yeah.
Any dose recommendation?
Well, yeah, I mean, obviously there is no everyone gives it a little bit different dose, okay? But if you want, like, if you want, what most people do is this is the dose. So prednisone 1 milligram per kilo per dose twice daily, okay? And then you might keep this dose up to like 2 weeks, 2 months, you know? So it depends of, everyone does it differently. But we can come up with something here. I did not specify how many weeks, you know, probably it all depends on the response. And if he improved the baby rapidly, I would not continue it forever. If the improvement is very minimal, you probably have nothing to lose by just continuing at least for 2 months, you know? So it all depends probably how brisk is the improvement. If it's brisk improvement, you probably stop it soon. If it's minimal improvement, you know, keep it. If there is no improvement, maybe you could argue just you should not start, you should not continue it, you know. So it all depends, but there is no like guidelines. Everyone does it a little bit differently, but at least we have a dose. We have we can give that dose and then go from there. And these are rare, you know, these are rare, you know, it's a rare disease, so it's difficult to have, you know, strong evidence-based medicine, you know, data, you know. So these are all multi-center studies. Most are retrospective, so every center does a little bit differently. So it's difficult to, you know, we only have a very few, you know, trials like I showed you, and the power of the trials is, you know, small, like 54 patients, 8 patients, and, you know, 20 patients. So it's a very small number of patients, you know. But I think there is definitely evidence that steroids and IVIG might help, and good evidence that hydroxychloroquine, the steroids and IVIG help in overall survival, and hydroxychloroquine helps in preventing the disease to begin with, you know. But obviously you have to take note of that you have to start treatment very early, which is the problem here. Usually the mothers are coming to us at, if you ask Dr. Mustafa, he will tell you, you know, they're already 6 months pregnant, you know, they already have complete heart block, they already have, you know, it's usually too late. Okay, so good questions. Bad.
دكتور محمد، يعني for hydroxychloroquine to work, it should be early before the child will have the heart block.
Yes, لازم before 10 weeks. Heart block develops after 10 weeks. So you started before the heart block would develop. عرفت?
Before the heart block.
Before, yeah, at 10 weeks and before. يعني say the mother is pregnant day 1, you start day 1 if you can't tell if she's pregnant. عرفت قصدي? So the moment she's pregnant and it's before 10 weeks, you can start hydroxychloroquine.
Do we have any case where we started hydroxychloroquine?
No, I'm here in Kuwait. Well, yeah, yes. So in our study, there are patients on hydroxychloroquine, but I don't know. I could not tell which week's gestation. It probably was too late. But there are patients that I think Dr. Mustafa, I don't know who, someone started hydroxychloroquine on them. For example, I'll show you now. Just a second. Here, look. If you see, like for example, patient number 2 had hydroxychloroquine. Patient number 6 was on hydroxychloroquine. You know, so very few, but at least 2 patients on hydroxychloroquine. But I imagine the diagnosis was they already had heart block and then they start hydroxychloroquine, which is too late. Because, you know, like, you know, our OBGYN don't refer them unless they see something, unless there's something, you know. But in this case, you want to refer just because there's history of heart block, just because there's history of maternal antibodies being positive. You know, you understand?
Yes.
Yeah, and in your clinic.
So I think we have to start like screening of the mothers for anti-Ro and anti-La.
Yeah, but how do you do that? It's not practical.
Especially if there is family history, previous sibling.
Yeah. This is our job. When you in your patients, if you have a sibling, if you take history and mom tells you, well, I have congenital heart block, I have abortions, you have to check antibodies. If she's positive, you counsel her, like next pregnancy, you come very early.
Yes.
Okay. Questions, guys? Okay. Questions? Manal, Hassan.
There is one question in the chat.
Yeah, I saw it. I'm trying to. So there seems to be an overlap.
Between
autoimmune.
cardiomyopathy.
أنا
أنا ماليش كأسفل. So
why am I here? Okay, so chat. Okay, so congenital heart block may or may not be related to Radwa. Congenital heart block may or may not be related to maternal antibodies. Okay, so but most likely if it's isolated, it's related. Like 80-90% with congenital complete heart block that are isolated, or mothers would be antibody positive. Make sense, Radwa? So rarely moms are antibody negative, but they have a baby with congenital complete heart block. It's very unusual, very rare. Okay. Did I answer your question?
Yes, Dr. Muhammad. Jazakallah khairan ala this lecture. I have one question. If I have one baby delivered this first day of life, and heart rate it is 70 to 90, and ECG show it is heart block, but 2-to-1 heart block.
Yeah.
You can give corticosteroid to prevent heart block, complete heart block, or postpone the incident.
I mean,
we have one patient, you remember, you included in this lecture, who died. Initially, he started with 2-to-1 heart block, and heart rate maintains above 80 to 90, and suddenly dropped to 40. We have any corticosteroid dexamethasone to start early if we have 2-to-1 heart block?
Yeah, again, our recommendations are going forward whenever, fetally, whenever there's any cardiac involvement, you have to give steroids. Okay. Now the baby is already born. Okay.
Born 1 day of 2 days.
Yeah,
earlier.
already born, and he's initially 2-to-1 and stable-ish, but then rapidly progress. So when he, you can look, giving steroids usually doesn't hurt. Okay, but so you can indeed give steroids, but in what we learned from our past experience, such babies are probably best to at least be at chest hospital if they are in Jahra or wherever.
Yeah.
And by the time, if they progressed, and by the time they come to us,
even without complete heart block, we bring to our hospital, or
well, yeah, because based on our experience, we did encounter a couple of babies, 2-to-1, heart rate 70, stable-ish by report. And then 3 hours later, they call us, he's arrested and he's heart rate 40, you know.
Yeah.
So there is, you know, so I learned this lesson that probably any form of heart block, you know, like it's high grade, you know, 2-to-1 and more, probably best served to be at chest hospital, you know.
Okay.
طبعا
Better.
the problem
بس
is the baby is complex, meaning he's very preemie, he's very عنده dysmorphic features, عنده multiple issues, عنده يعني many issues, kidney issues, whatever issues. Then it's because this is the problem with the Kuwait, and we don't have children's hospital. So when they come to us, we focus on cardiac, but we are weak in other stuff. But this is the problem. Such babies are not, best served in our country because we don't have children's hospital that includes all the specialties. So we have to
Yes.
balance, of course. And if the baby is so complex, the question is he better off not paced, but there where they take care of the baby as a whole, or he's better off coming to us, we pace him, but we might not treat him very well for the other stuff. You know what I'm saying? So,
Yeah.
I don't know. It's probably will be very tricky, but in generally, if the baby is good enough to come to us, if we can manage him, our ICU can manage him, it's probably better to be with us,
We can arrange for portable يعني temporal pacemaker in other
Yeah,
hospital.
I know, but
Arrange equipment.
but they will
system.
not accept him back if he's sick, So they will, they will tell you, okay, let's say he came in, lactates were 4, for example. We gave him the temporary, lactates are 8 now, They will say, no, lactates are 8, he's showing signs of progression. We will not accept him. He's not stable to go back, Blood pressure, let's say, was 45, 50, went down to 43, for example. They would, they will give you hard time accepting to receive the patient back at least.
No, I mean
they
we
want
can
you
do there in other hospital. يعني
yeah, well, they can
we
do that.
can arrange equipment and everything.
Yeah,
to,
but then their anesthesia would need to accept, So I don't know. I mean, we Mustafa and Jarrah, mentioned this previously, but I don't know whether they are, someone has to approach the anesthesia of Farwaniya, anesthesia of Jahra, anesthesia of maternity, anesthesia for wherever, and see whether this is doable, I'm not sure this is doable.
Especially this particular patient is one of the achondroplasia. You said 2 patients. This was one of them.
Yes.
And
true.
initially he was not a complete heart block.
2-to-1.
First day of birth, I think even was not 2-to-1. As per
he was okayish. I think he was 2-to-1. I think, but then he rapidly progressed, and then
hours.
The problem also, what I learned from my experience, people call you, they say, the patient is stable and they give you a couple of numbers, but actually there is, pleural effusion, there is ascites, there is, generalized edema, but they fail to recognize, any evidence of hydrox. They focus maybe on the blood pressure and the heart rate, but there is definitely other signs of decreased cardiac output, But, they don't do ultrasound of the abdomen, for example. And then when they do ultrasound, there's, by the way, there's ascites. But so meaning he was not really truly, stable. He definitely has, heart failure symptoms. So I learned that people, when they sign out the patient to us, they might miss, that the patient is truly sick. They might, be, they might miss all the symptoms and signs of decreased cardiac output and perfusion. So don't trust someone telling you he's stable. You have to really take all the numbers, all the labs, all the imaging, and ask for everything before truly calling this baby stable and asymptomatic, and no need. There's no need for pacing. Most will require pacing, almost, very, most of them will require pacing. It's very difficult for a baby with, congenital complete heart block not be paced. Usually there is something that something that would, make the baby meet the criteria for pacing, So anyways, especially if they present at birth, if they present obviously at 5 years of age, then sure. But if they are presenting at birth, usually there is, you can definitely find a reason to implant a pacemaker. Okay. Anyways, Hassan is saying digoxin. Hassan, digoxin will not affect the AV node is already dead. So the digoxin will not affect the conduction. So already there's no conduction. Okay. So the digoxin will improve hopefully the function, and the rate will remain the same. Makes sense, Hassan?
Okay, thank you, Dr.
Yeah.
Yes, got it, thank you.
And then there's a question: is it recommended to start steroids in all patients with congenital heart block newly diagnosed prior to? I mean, again, there is no, IVIG is lots of volume, so just be worried about the volume. You can do it over 2 days, but generally we can start steroids and IVIG, sure. But is there strong evidence? There's no strong evidence. Okay, DEXA may cause some brain issues in unit. I think prednisone is better. Yes, so I'm telling you, prednisone is Nabil. Prednisone is for babies. DEXA for pregnant mothers. Okay, but if you mean DEXA for prednisone for pregnant mothers, again, there is 109. There's this paper that I presented with 109 or 106 babies. I forgot how many. So large volume, all on DEXA, and there's no brain issues. Okay, Nabil. So the evidence of DEXA causing brain issues is very, very, very minimal. Okay.
انا قصدي يا دكتور محمد زي ما حضرتك بتقول بعد الولاده يعني افتر بيرث.
لا، the prednisone. Yeah, but
دكتور محمد البلس سترويد المثال برينيزولون، احنا كان في جربنا مع عيال ال 221 ده مثال برينيزولون. هل ده ممكن نستخدمه يعني
اي في يعني
اي في يس اي في اوكي.
Yeah, طبعا هم usually intubated and stuff, so usually you have to give not oral IV يعني. Okay. Anyways, our, in generally, most of our babies that we had recently, they had decreased function. They had, even our 2 babies that are just discharged, or one of them discharged, one of them is hopefully discharged soon. They both had not a perfect function. So they all had risk factors for mortality. Okay. We did not have very straightforward congenital complete heart block recently. Okay. So don't be surprised that the outcomes sometimes are bad. It's just the nature of the disease, especially that we're not aggressive in fetal management. Make sense, guys? Okay. Okay. I don't know, Mohammed Mitwali, brain issue stuff details. I don't know.
ده انا بسأل نبيل بقول له ايه البرين
I think he's right. There is حتى حق المother it causes psychosis, it causes mood disturbances, but I don't know there's definite
هو كان عليه يا دكتور محمد كلام ان هو بيأثر على البرين ديفلوبمنت السايز بالذات بتاع البرين.
Yeah, but I don't think it's a very strong evidence. At least in the يمكن is old papers maybe, but I did not see. Again, they are using it so the papers that I presented all from a major, European, Canadian, US centers, they're using dexamethasone. Okay, so I don't think. Yeah.
ممكن معلش كمان another question. هو ممكن الكومبليت هارت بلوك we can temporarily do pacemaker during transvenous pacing or should be implantation of the pacing?
You mean permanent?
Temporal transvenous pacing.
Yeah, we have
temporary مش
temporal. temporal.
Yeah, we can. We said we can.
Save time and save the baby. It is complete heart block. It is easily management if early diagnosed and save the baby and complication. We try to get any easy method to get early implantation, temporarily transvenous.
Yeah, but even transvenous, we said this, Manal, we can obviously, but the problem transvenous, you still need blood, availability, you still need anesthesia to clear the patient. So the amount of hours that you have to wait for the blood and patient to be ready is roughly the same. Okay. The procedure itself is probably a little bit shorter, but sometimes access takes 2 hours. You had seen sometimes access takes 2 hours. So anyways, the procedure itself is probably much simpler, much quicker, but there is risk of perforation, of course, and it's not as stable as the epicardial lead. Obviously, like I said, there are two different schools. I told you we can do both. We had done transvenous in the past here in our country, and we had two perforations. Okay, so it's something that we have to be aware of. Epicardial, usually no complications, except that it's just a little bit of a, it's not the opening is not, it's usually it's a relatively quick surgery. But obviously you can do transvenous epicardial, no problem, but
before we used to do this transvenous, we never informed the surgeon that we have congenital complete heart block, and was going firstly to the cath lab for transvenous. But we found the epicardial is easier and the complications is less.
Where
is not capturing.
Yeah. And I'm used to epicardial system, temporary, sorry, even when I was
as a temporary, yes, as a temporary.
Yeah, we always do epicardial pacing system, temporary. But there are groups that they do transvenous routinely. That's fine, whatever you're comfortable with, whatever. If your surgeon say if the surgeon doesn't want to do temporary epicardial, then you're stuck. You have to do transvenous, for example. If you have no surgeon, you have to do transvenous. If you whatever, you can still do transvenous. But I think epi is a better option.
I think so.
Yeah.
According to our experience here.
Yeah, but anyways, either way is fine. The babies are sick, and you just do whatever you can to for the baby to survive. Okay.
Thank you.
So I think good question, good discussion. I'm not sure, someone who said neonatal steroids affect neurocognitive function, that's why they are reviewing. Yeah, so there's probably some mood and neurocognitive dysfunction that might may not be obvious when during infancy and neonatal period, might be obvious later. But anyways, again, the survival is major. The survival is much better with usage of steroids. So which one is better? Concerns of neurocognitive issues versus better outcomes. So I don't know. You have to balance. So.
And on the other hand, some people, they give steroids for any patient neonate going for a bypass surgery for neuroprotection.
Oh, I see. Yeah. I mean, that steroid literature about brain and steroids, I'm not very familiar with. So maybe someone can review it and we learn something about it. But according to what I know, people use steroids all the time. And, no major concerns, at least short term.
Yes.
Okay. Thank you very much. I hope it was helpful. And then we'll discuss with Dr. Mustafa our brief protocol and see, and then we'll adjust accordingly, and then hopefully we'll come up with something. Okay, guys.
Okay.
Thank you.
Thank you, Dr. Muhammad.
Thank you.
Thank you very much, Dr. Muhammad.
Thank you.